Thank you so much for that kind introduction, and thank you for allowing me to speak this morning. Some of you may ask, why is an infectious disease doctor talking about cardiovascular risk? And I'll meet with the residents sometime to give that story, but the short answer is I trained at the Cleveland Clinic, so you can never escape heart disease. So the objectives of today is to demonstrate the growing importance of screening for cardiovascular disease among persons who are infected with HIV, evaluate how to assess cardiac risk in HIV-infected persons, and to distinguish the differences between the Framingham risk score and the 2013 ACC-AHA risk score. So first, just a brief review on aging with HIV. What we've seen over the past 20 years now is that there's been a tremendous increase in life expectancy on patients who are taking antiretroviral therapy. However, life expectancies are still shorter than the general population, not by much, but in modeling anywhere from 4 months to a few years. But it's even more so true for people that have very low CD4 counts and are on salvage regimens. But the life expectancy is impacted most by non-AIDS related comorbidities. So people aren't dying from HIV-related diseases, but rather from other comorbidities, the same as the general population. And what's really interesting is that we see this increased prevalence at every age. And so the appropriateness of primary care guidelines, whether it's colorectal cancer screening, doing CHD risk, is really unknown, and there is no systematic method to predict whether the guidelines developed on general population should apply to individuals with HIV. I always say we should do at least what we do for the general population, but maybe there's more that needs to be done for these special populations, and not just HIV, but any inflammatory state such as like rheumatoid arthritis. So antiretroviral therapy is known to produce chronic adverse effects, and the risks for cardiovascular disease was greatly increased, and there was more metabolic abnormalities. As we now have a new class of drugs, the integrase inhibitors, we're not seeing this as often, and by far the metabolic syndrome and complications from HIV therapy has decreased. But antiretroviral therapy may not protect from cancer with age. There's no reason to believe that by giving antiretroviral therapy, you're going to really reduce that traditional risk for colon cancer or lung cancer. But all these conditions can be seen at an earlier age, and even things like osteoporosis and hypogonadism. So I just want to briefly go over the results of the START study, which just came out in the New England Journal of Medicine last week. And so this was the strategic timing of antiretroviral therapy. So these were HIV-infected, antiretroviral therapy naive individuals who had a T-cell count of greater than 500. There were 215 sites globally. And patients were randomized like a flip of a coin to either start HART immediately following the randomization or wait until their T-cell counts went less than 350 or they developed AIDS. And on May 15th of 2015, the Data Safety Monitoring Board determined that all patients must be offered antiretroviral therapy because of the findings. So let's just briefly look at this. So this is the immediate group who got antiretrovirals right away, and this is the ones that waited. I will note that these events occurred before these people reached 350. So the median CD4 count was actually in the upper 400s at the time of the event. But you can see that in those that got therapy right away, there were only 42 events, and there were 96 events in those that deferred. And by far, you can see it's mainly serious AIDS, and not surprising because this also occurred in several sites in Africa that TB was there. But surprising for us, we did see Kaposi sarcoma and lymphomas. But more so, when you start looking at what these serious non-AIDS events, which again were statistically significant, not individually by themselves, but taken together, and it was other cancers. And this is a smattering of cancers. It was thyroid, lung, prostate. It was just a mix of cancers. And what was really striking when you think about this was that the median age is 36. So not what you would think of as having events. And cardiovascular disease, actually it was equal numbers at this time between those two groups, and we're following this group out for another year and a half, so hopefully we'll have more data. But you can see that not uncommon. Traditional risk factors, 30% was current smokers, 50% had at least one Framingham, 20% hypertension, 8% dyslipidemia, 3% diabetes, 2.9% Hep B, and almost 4% Hep C. And then actually this was quite low for alcohol and substance use. So, and we're looking at a rate of, it was about 0.2 per 100. Which isn't that far off for the general population, a little bit high for this population where really there was skewed more a little bit in the ages of upper 20s to maximum age in the low 50s. What we do know is from many observational cohort studies that cardiovascular disease risk is far beyond that's predicted by traditional risk factors. And so you can see going back all the way from a Kaiser Permanente study in 2002 up until the Friedberg study, and this is the Veterans Aging Cohort Study that showed the hazard ratio of MI was 1.48 in HIV versus non-HIV veterans, and that was after adjusting for the Framingham, all the comorbidities, and including substance use. So this has been a consistent finding. There's many other cohort studies, but I just put kind of the big leaders that have very large sample sizes in here. But let's drill down a little bit more on Kaiser Permanente. Kaiser Permanente, as you know, is everybody's on their plan, and it's really a pretty stable cohort of patients. And they have greater than 35,000 HIV-infected patients they provide care to, and over 6 million HIV uninfected individuals. And at this time, this was looking at the incidence of MIs and strokes between 1996 and 2008. And what you see is a relative decline in events. This is MIs and this is stroke going up to the most recent on this paper through 2008. And you said, well, why are we seeing a decrease? Well, one was that there started to be better HIV drugs. So stavudine or D4T, that was a nucleoside that was associated with mitochondrial toxicity, affected the sterile regulatory element binding protein pathways, so we would see this hypertriglyceridemia. So that use has really gone down. In fact, nobody really prescribes this drug anymore except some resource-limited settings. And then you saw the percent of individuals who were taking tenofovir, which is the more favored nucleotide now, which actually is more metabolic friendly, and then the patients that were treated with a newer PI at this time, atazanavir. And then they said there's also more attention to lipids, and this was pretty good. 33% of those that were on protease inhibitors actually were on lipid-lowering therapy. So we got better at recognizing who was at risk, who was having abnormal lipids. We switched off the more metabolic toxic meds, and so things were looking better. But when you actually look, again, more at the KP data, that the nadir CD4 count, so the higher your CD4 count is, the more protective it is. And then not surprising, you see the traditional risk factors of smoking, overweight, diabetes, hypertension, et cetera. But duration of HIV and whatever that nadir, the lowest point of your CD4 count, seemed to play a role in who was at risk of having myocardial infarction. So this is KP's most recent data, and you can see now they're up to 2011. And again, what's interesting is the incident rate has really gone down, and it's to the point now that it's almost meeting with the general population. So again, better drugs, earlier diagnosis, getting people on antiretroviral therapy right away, and starting lipid-lowering therapy or treating hypertension as needed right away to reduce those risks. Let's see what's happening in New York City here. So this is the percent of all deaths, and this in the blue lines showing HIV-related causes of all deaths. And you can see, again, thanks to antiretroviral therapy, earlier diagnosis, we're continuing to decline. And this is the general population, and you do see that over time we're increasing the risks of cancers and major cardiovascular disease. If you look at how many cardiovascular disease deaths per 1,000, and this is age standardized data, you actually see for both HIV-infected men and women that this rate is lower, although the women here are higher than the general population of women. The men, here's the general population of men, HIV infection is actually decreased. But what's really interesting is when you look at this from an age-adjusted manner, and you can see that when you're younger, there's this higher risk. And then as you get older, you're meeting the general population. So questions being, one is, we don't have that many individuals with HIV up here, so this affects the statistics on this probably. But this 65 to 74 is approximating, and it's probably at that time where traditional risk factors for both the general population and HIV are similar here, and HIV maybe is getting outshined at that moment. But why do we have such an increased risk in our younger HIV-infected persons? And that's what we've been trying to understand is, what is this? Is this, related to residual viremia? Is this, that the immune system there is heightened activation? What is the precise mechanism that's kicking off, presumably, these inflammatory cascades and us being associated with development of comorbidities? And interesting enough, the cardiovascular disease mortality was lower among HIV diagnosed individuals who had suppressed virus versus an unsuppressed level, and that was pretty high, 3.9 versus 7.7. So here's a question for you guys. Well, there's a general agreement that HIV itself contributes to risk for cardiovascular disease. A recent study reported which group of patients, based on their HIV viral load, had the most hospitalizations for cardiovascular disease. So one is virologically suppressed, taking their antiretrovirals, and the viral load's now undetectable. Those that are on antiretrovirals but have low-level viremia, meaning that they have less than 1,000 copies per ml in their blood. The elite controllers, which are individuals that are able to control the virus by themselves, they don't need to be on therapy, and their viral load is undetectable. Or those that have high-level viremia, meaning that even despite therapy on salvage regimens, they have virus loads greater than 1,000 copies. So how many people think it's number 1? Number 2? Number 3? Number 4? Yeah, and if you would have asked me this question before this study came out, I would have said it was number 4, but it's actually number 3. And this was quite a surprise, and this is actually coming from the HIV Research Network, in which the St. Luke's Roosevelt hospitals are part of this and contribute about 7,000 patients to their overall 25,000 patients. And you can see here that the elite controllers by far had more hospitalizations. The people who were on antiretroviral therapy and controlled were the lowest, which we would have predicted, but here's the high-level viremia, and it's significantly less than the elite controllers. And so why would that be? These people have no circulating virus per se, right? But they do have heightened immune systems. And so it's really interesting. You can see the elite controllers had more cardiovascular admissions and more pulmonary admissions. And there's a lot of thoughts behind this about maybe it's something unique to the elite controllers that has them be able to control their virus, right? And so there has been some work done in the CCR2 receptor, which is associated with laying down a plaque in the endothelial linings, and those same polymorphisms that are associated with increased plaque development are also found in the people who are elite controllers. But they haven't been able to do a one-on-one. That was one study, and unfortunately I haven't seen any more about that, but I think that's a really interesting finding. So this was my view back in 1998. I actually thought I knew a lot, because it was like we had HIV, there were metabolic complications from antiretroviral therapy, traditional risk factors. Of course, these people are at risk for, heart disease. And then came along this question, what is chronic inflammation? And then there was the question of, what about endothelial dysfunction? And again, we thought endothelial dysfunction actually was related to some of the side effects of the protease inhibitors. And then in 2004, we started getting more knowledge, and we said, well, these are in the risk calculators. These aren't included. chronic inflammation became more in the forefront, as did our understanding of how HIV affects endothelial dysfunction. So we've come a long ways, and I think more now than ever. I really don't know. I feel like I'm regressing in my knowledge base, but we keep trying to find and understand what the mechanism is, and until we have that mechanism, it's a little bit of trial and error trying to really treat these individuals and to prevent cardiovascular disease. So this is the old calculator that most of us were using, and many still are. I say age, gender, total cholesterol, HDL, really built on the non-HDL number, whether or not you're smoking, systolic blood pressure, and whether or not you're treated for that. And remember that this risk calculator was used for those that had 2 or more risks. And this was the typical thing we'd do in front of our patients. We'd say you have 16%. You'd say, you know, if I took away smoking, you'd be down to like 5%. So isn't it better to stop smoking than giving a statin? So we tried that for a while. But what was really interesting is looking at a cohort of patients from, and this was, again, a large international study looking at adverse events from the HIV medications, and wanted to know whether or not the Framingham really was valid in HIV-infected patients. And I think it's really interesting. This is the duration on the bottom here of how long people were on, and this is a European term, combination antiretroviral therapy. So they always call it CART. We just say ART in the United States. And this was what these patients were estimated to be, and yet this was the actual rates. So it was close. I mean, it runs pretty parallel, but it appears to be about 1% or 2% higher than what Framingham would predict. And now, of course, we have this new one, the ACC-AHA risk calculator, which adds on a few things. You have diastolic pressure, as well as you have a race involved here, which was not accounted for in the previous NCEP. But one of the concerns about the new risk score is that there is a possible overtreatment in our older patients. So if you look at these 3 individuals, you have a 60-year-old African-American male, a 65-year-old African-American woman, and a 60-year-old Caucasian male. Their cholesterols, right, we do non-HDL, they're all pretty good, 120. They have good blood pressures, they're not on treatment for blood pressure, they don't have diabetes, and they don't smoke, yet this risk score is 7.5%. So would you treat them with a statin? And I can tell you, as I'm screening now patients in the clinic, we've found people who are even younger, in their 40s, who are a smoker, who don't have any other comorbidities, and their risk score comes out to 7.5%. So I think we need to really think about how this risk calculator is used, and then what the guidelines actually say. So this was a group out of Boston. This is Markella Zani working with Steve Grinspoon, who's an endocrinologist at Mass General. And so what they did is, and this is a very select study, so be cautious how you interpret this. It's only 108 patients who underwent CT angiography. And what they looked at was non-calcified plaque, which they call high-risk morphology plaque. So in this, if you look, these individuals did not have any coronary plaque, whereas these individuals did, that had what they call 1 or 2 features of high-risk morphology plaque, meaning that this was plaque that could rupture. And so 74% then that had this high-risk morphology would not receive the recommendation to go on a statin, yet 19% without it would receive a statin. So, these guidelines are difficult to apply to the HIV-infected population, and let's face it, we're not going to have all our patients do CT angios. So, is there a better way that we can determine who is at risk? So just briefly to review again, the 2 risk calculators is the ACC-AHA one, which is pooled cohort risk calculator in non-Hispanic whites and non-Hispanic African Americans aged 40 to 79 without atherosclerotic disease and not on a statin therapy. And then they say that you consider assessment of lifetime risk for those aged 20 to 59 with no atherosclerotic disease and not at high short-term risk. NLA sticks with, and this is the National Lipid Association, they stick with the old National Cholesterol Education Program way of counting the number of major risk factors and use other risk indicators for making that decision. And they say they don't really care which calculator you use. You can use the Framingham calculator, you can use the ACC calculator, but you should decide which one you're going to use and then be consistent that you're always using the same calculator every time you see that patient. But now the prevention approaches are different. So this is the management of blood cholesterol from ACC/HA, and then the National Lipid Association came out with their recommendations for dyslipidemia in 2014. So there's a lot of similarities. One is lipid screening is recommended at 5-year intervals, despite Mount Sinai saying all employees need yearly lipid panels. Whoever makes that decision, I hope they change it. I think it's a waste of money, but that's what we're told to do. Lifestyle therapy is advocated as the first step, as it always has been. And the goal of therapy is to reduce your risk of having an atherosclerotic event, right? And moderate or high intensity statins is a central focus of both for what is your first line therapies. And both say that there should be a patient-provided discussion of this risk-benefit ratio before you prescribe a statin, and regular lipid follow-up is warranted to assess adherence to therapy. All right, so lots of differences though, and I won't go back over the risk calculator, but evidence-based. So the ACC only uses randomized controlled trials that have atherosclerotic cardiovascular outcomes or meta-analysis of these. And so one of the difficulties with this is who goes into trials? Well, they always have fixed inclusion-exclusion criteria, so you're going to have age bracketed, right? That's why it's 40 to 75. There also is no dose titration typically in a randomized controlled trial. You don't go treating to reach a goal in these randomized clinical trials. What you do is you look at what your percent reduction is, because it's looking at what the efficacy is, what the percent reduction of that drug is. So from there, it's hard to jump and make that conclusion that you need to use lipid targets because you have no data in randomized controlled trials. Where the NLA says, yeah, we recognize these are very important, but we also know that we get our best outcome data from observational epidemiologic studies, and they have a number of selected post hoc analysis of the randomized controlled trials, as well as using some of these other mechanistic studies and genetic studies to help determine what's the best way to treat. All right, so what's the central focus? Well, the ACC really is designed to identify who's going to benefit from statins. And it's the initiation and maintenance of high and moderate intensity statin therapy. The ACC doesn't say you can't use lipid goals. I just want to say that because people think they say, oh no, lipid targets. They don't recommend for or against it. All they can say is that wasn't what was done in the randomized controlled trials, so we do not have evidence for it. It doesn't mean that you can't use it. And it's recommended against non-statin therapy because there was less favorable net benefit in the randomized controlled trials. So the NLA is a little bit different because it looks at that whole risk based on clinical parameters and risk factors. Again, you're looking at initiation of atherosclerotic disease risk-based lipid-lowering therapy. So depending what their lipid is when you're going to initiate. And then maintenance of lipid goals to assess effective reduction. And then they do use moderate and high-intensity statins, but they also say if you need other things to meet those goals, you should go ahead and do it. So I think we're familiar with this because this is what the National Cholesterol Education Program was using before, where you actually have when you should consider drug therapy. Remember, the ACC starts if anybody has greater than 190, a statin would be a benefit. So here you can see, and this is what your treatment goal is. And so depending on the number of risks that you have, your goal could be anywhere from having an LDL of less than 100, or having it less than 70. And this is the general frame of approach for the ACC guidelines. You know, if you have clinical atherosclerotic disease and you are over the age of 75, you get to stay on your statin, you know, but otherwise, remember they have that 40 to 75 approach and say they don't really know. So LDL is greater than 190, having diabetes with lipids between greater than 70 to 189, and then if you have greater than 7.5%, then you should consider the benefit of statins. Again, no defined lipid targets. But the question is, how do you apply this to HIV? There's no data on HIV. HIV hasn't been around that long to have 30 years of epidemiologic studies, nor has it been that we've had potent antiretroviral therapy for such a long time that we really have really good outcome studies. And again, just a reminder about these statin groups, because each one of these is an indicator for a statin, and you only do that equation for people that don't already meet criteria to be on a statin. And I say that because there's been some interest about having this automatic in EPIC, and if we do that, we have to remember that some people shouldn't be done. So in point of fact, we had a patient with diabetes who had an LDL between 70 and 189, obviously would benefit from a statin, but their risk score was calculated, and even though it still came up with statin, it was only 8%. And so I just am concerned that if we start using an equation for people who you shouldn't use the equation for, you could come up with some bad knowledge and even potentially make wrong treatment decisions. So remember to use them. So I just want to briefly show some studies that the NLA did consider that were not considered in the ACC. And you can see this was published in Circulation. This was looking at U.S. age standardized death rates attributed to cardiovascular disease. You can see here's the release of the original NCP guidelines. And this is all-cause mortality here, total cardiovascular disease mortality. And here's the more enhanced one with the stricter criteria of getting your goals down lower. And you can see that the events decreased. Stroke went down some. We didn't see other CVD really change, but certainly coronary heart disease has decreased with this. Now, when you look at through 105 million patient records, you can see that since 2008, we've kind of plateaued on where we're getting our mean LDL scores at 105. So from the NLA perspective, we still have a long ways to go with getting rid of cardiovascular disease deaths, and we haven't really maximized what our mean LDL is. So again, kind of pushing, inferring the data about how maybe we should be having LDL goals. And this was another observational study, clearly over 2,000 patients with familial hyperlipidemia that did not have coronary heart disease at baseline. And you can see that having a statin was associated with a longer event-free survival. So supporting, again, the use of statins. Again, a study that wouldn't be included in the ACC. So let's shift gears a little bit now, because what are we dealing with? So we have the HIV population. The question is, what statins can we even use in the HIV population? Some of the statins, the two that are the high intensity statins, actually have interaction with protease inhibitors. They actually have interactions too with the non-nucleosides. So they're a little bit limited. And even though the new integrase inhibitors for the most part don't interact, one of the more commonly prescribed one has a pharmacokinetic booster called cobicistat in it, which does interact. So we have a problem with what statin can you use. And people would criticize and say, hey, you guys aren't maximizing statins. But remember, if you're on a protease inhibitor or you're on a cobicistat containing regimen, 40 milligrams is equivalent to 80 milligrams. So they are, in fact, on high intensity statins. And yet you can see, your percent reduction, 29%. And you can see here pitavastatin having probably the highest, although this is not head-to-head, so by no means can you really say that one is better from the other on this. But the advantage with pitavastatin is that there are no interactions with any of the HIV medications, and there is no effects on glucose homeostasis. And that's a problem for us because our patients have underlying insulin resistance, can be worsened by some of the therapies. So we have to be cautious when we use the statins to make sure that we're not affecting their glucose levels. So what are the good things about statins? So statins reduce inflammation and coagulopathy. So statins directly inhibit expression of IL-6 and therefore high sensitivity CRP, which is a down product. Tissue factors such as D-dimer, soluble CD14, TNF-alpha, and a whole host of other things. And there have been clinical trials that have demonstrated that these biomarkers improve. We've seen this in sepsis, COPD, hepatocellular carcinoma. And then we had the rosuvastatin study, the Jupiter study, several years back that showed there was a decrease in morbidity and mortality in venous thrombotic disease and cardiovascular disease in subjects who had a CRP level greater than 2 and had normal lipids. So they didn't have an explanation for why their CRP was elevated, but this study was halted by the Data Safety Monitoring Board after 1.9 years because there was an overall reduction in cardiovascular disease and all-cause mortality. And I won't go into the arguments back and forth about this or not, but it was really interesting. We have not been able to find the same thing in HIV of what that marker really is. So to be a useful marker, it has to be able to predict clinical disease. It has to reflect the key pathophysiologic process mediating the risk of the disease. It's got to be responsive to the intervention, and it has to have good reproducibility. And I can tell you many of these markers, like IL-6, for instance, we're now to the point that we collect them about a week apart, and we take the average because there's so much variability in those assays. So we really don't have a marker that we can use in HIV. We don't know what that pathophysiologic process is that's mediating their risk. But what can we agree on? We can agree that antiretroviral therapy has dramatically increased survival. And this increased survival has been associated with an increased prevalence of non-HIV related comorbidities, and that these comorbidities may occur at a younger age in HIV. And we need to inform our patients of this risk, and that at all ages that there's a higher prevalence of these comorbidities. We have a lot to learn understanding the association of what's happening as our patients with HIV age, and we need markers really to really determine risk and prognosis, because right now they have not been validated in this population. So where does that lead me? It leads me to my job, I guess, and that's to do large randomized controlled trials, because we need to inform clinical practice how best to do this. So HIV patients, again, with low traditional risk scores, still are at increased risk for cardiovascular disease due to the subclinical plaque and inflammation. It's unknown if statins will prevent cardiovascular disease and should be recommended for our population. And though, it's been really, for the most part, statins have been well tolerated. Those studies have been small. There's no data from any large randomized controlled trials in HIV really investigating tolerability, what the long-term AEs or efficacy are, and how will statins uniquely work in HIV besides LDL lowering. What are the effects on the inflammatory pathways? So that leads us to the REPRIEVE, which is a randomized trial to prevent vascular events in HIV. We now have 6 locations in Mount Sinai at all our HIV clinics that we are now consenting patients to enroll in this study. So we want asymptomatic HIV patients that have no history of cardiovascular disease and the 2013 ACC risk score of less than 7.5%. We're going to enroll 6,500. This is an international study for 6 years. They're randomized to either get pitavastatin. Why pitavastatin? Because there's no drug interactions. We don't have to do any dose reductions. This is the best drug to use for this particular study, mainly due to the drug interactions and also because the potential with the glucose side effects. And then placebo. There is a mechanistic sub-study that we're doing here at Sinai in which people will get CT angios at entry and at year 2, as well as a whole host of inflammatory and immune activation markers. And then the primary event is what we call MACE, major adverse cardiovascular events, as well as we'll be looking at all-cause mortality, and there's probably at least 50 other sub-studies and other endpoints being looked at. Christina Wyatt and myself with a group from University of Alabama will be looking at statin effects on the kidney as well. So we started enrolling, and what we found is all we're enrolling is younger white non-smokers. So the National Heart, Lung, Blood Institute pulled together a data safety monitoring board and said that African American participants and smokers were often excluded at very young ages, and despite the uncertainty about the use and efficacy of statins among HIV individuals with such risk factors. So they met, and they've now recommended us to up the entry to less than or equal to 10%. And they base this saying that there is no trial data validating this risk prediction equations in the HIV population. There are no definitive data to know what the use of statins in this 7.5 to 10% range is. And the use of statins is not mandated by any clinical experience or guidelines, allowing for the necessary equipoise for inclusion of this group in REPRIEVE. So what do you do when you don't have any answers from clinical trials? You get a group together and you make a panel and you put them together and you say, hey, we need some guidance on how we should manage people in the meantime, because we're not going to have the answer from REPRIEVE for 6 years. So the National Lipid Association put together a panel, part 2, which is looking at rheumatologic disease and HIV, as well as other special populations like pregnancy. And I became the chair of the part 2 for HIV, put together a panel of cardiologists and HIV experts. And then it went back to the NLA. It actually was released out for public comment. We've received all the public comment back, and we're now ready to finalize it. And this was more or less what the NLA decided, that results from observational studies support that there is an increased cardiovascular risk in the HIV population. However, there is a paucity of data linking cardiovascular outcomes with lipid goals, and no validated risk stratification schemes for this patient population. And the expert panel recognized the paucity of data from the randomized controlled trials with CV outcomes in patients with HIV to guide decisions on when to intervene. So the bottom line was there was insufficient information to make any definitive recommendations at this time. And we said, well, that's bad, because our introduction was saying, well, just follow part 1. And we said, well, let's really do a really profound literature search, and what do we want to do? So this was the final upshot of this, was that given the strong data indicating that HIV infection is a risk factor for atherosclerotic cardiovascular disease, the expert panel believes that clinicians should have frank discussion of the risks with patients and consider HIV as an independent risk factor that should influence when to consider drug therapy for lowering atherogenic cholesterol. So HIV infection can be considered an additional major risk factor when counting risk factors for that risk stratification. So remember when I showed you the table before, and it's 0 to 1 risk, or 2, 3. HIV itself will now be considered one of those risks. And so, you're back to, well, what are we doing with REPRIEVE? And really, the NLA, their interpretation through the ACC is that patients really shouldn't be offered, they must be offered a statin until you hit like 15% risk. And in fact, the NHLBI even considered doing that with REPRIEVE, and somehow, I don't know what they decided because it's closed doors, but they came up with a 10%. But I think it's really tricky on how do we assess risk in cardiovascular disease in our patients, and then once you do determine that risk, I think we all agree lifestyle, but we really need to think about that next step of whether or not to give a statin. So in conclusion, traditional and non-traditional risk factors contribute to this increased risk, and controlling viral replication should reduce the risk. We have no reliable inflammatory markers, though, to predict risk. And we know that Framingham and the ACC most likely underestimate risk in most people, although remember about 20% and even more for the Framingham are going to overestimate their risk. Count HIV infection as additional risk for the risk stratification. I can't emphasize the smoking cessation enough, and then dietary and exercise interventions. But as far as statins, what I can say is they may be a benefit in addition to lipid-lowering effects like we see in the general population. However, we have no data right now to recommend their use outside of the current NLA or ACC guidelines. So I'll stop here with just, if smoking relaxes you, then don't quit. Being dead is very relaxing. So thank you all very much.
Thanks very much. Virus causing cardiovascular disease directly without lipids as the intermediary is the heart of my comment and question for you. So first, your professorship, George Baehr, links to that comment of mine because a million years ago, maybe 100 years ago, he wrote a monograph on lupus, which became a classic. So there's another vascular disease like the one we're talking about, in a sense, and possibly virus related. Do you or any of your colleagues look at the virus as a direct cause of atherosclerosis without lipid intermediary?
Yes, I mean, so the question is, have individuals looked at how HIV itself may directly impart upon coronary heart disease? And so we do have studies showing that HIV itself doesn't, in fact, there's a few things that it can do. One is there's been associated cardiomyopathies. There is direct effects on the endothelial wall, and then you do have, right, all this immune activation going on, such as your elite controllers, right? That's really, when you're looking at elite controllers, they're not on therapy, and it's not related. The LDLs are okay, so why do they have this non-calcified plaque? So there is something there. The question is, what is causing that? And so, you know, that's the big key. We don't understand that precise mechanism, why that's happening. But I think the elite controllers do offer us insight into what HIV may be doing.
Excellent overview, Judy. There was a revision of the ACC-ACD risk score, which was published in JAC and Baehr Bogan, and they actually looked at sex and decile of age, and they improved specificity without losing sensitivity. With regards to the question about what else, we're doing the cardiovascular risk inflammation trial of methotrexate in non-HIV patients, but the NHLBI has sponsored a trial in HIV patients to look at a non-specific anti-inflammatory agent, see whether it can actually reduce events in HIV patients. There may be the chronic immune reaction in the arterial wall that's contributed to higher event rate even in people on statins.
Yeah, and so Dr. Rosenson's commenting on the use of anti-inflammatories in individuals with HIV and coronary heart disease, and even without. And Paul Ridker, who did the Jupiter study, actually is the chair of a large methotrexate study in the HIV population as well. So I think we're trying, again, we're doing all these different interventions, but the one thing that we're missing is, what is it doing? And some of the statin studies have been kind of interesting on what they're showing us, and it's inconsistent. Every statin, you might see one change here or there in a biomarker, but we really, again, it's that key question: what is the underlying pathophysiology? And again, this applies to those with rheumatologic diseases and other types of inflammatory diseases.